Good afternoon and welcome back to HealthLeaders, the Winning Edge program, a weekly series of webinars touching on the topics and strategies that you need to know most. My name is Jay Asser. I'm the CEO editor for HealthLeaders and will serve as your moderator for this session. Today's webinar is titled The Winning Edge for Battling Medicare Advantage. Thank you to you and our audience for participating. Before we get started, for those of you participating in the live program, I just have a few housekeeping details to go over. Our program will be approximately 60 minutes in length. Note that an on-demand version of this program will be available on our YouTube channel on Friday and can be accessed through our website, healthleadersmedia.com. To ensure that you can all see the content for the event, please maximize your event window and be sure to adjust your computer volume settings and/or PC settings for optimal sound quality. Next, you'll find a resource list for today's webinar on the upper right of your screen. Here we have listed the webinar slide deck for you to download along with a registration link for future The Winning Edge events. At the bottom of your console are multiple widgets you can use. To submit a question, click on the Q&A widget. It may be open already and appear on the left side of your screen. You may submit questions at any time during the presentation. However, please note that it is likely that your questions will not be answered until the very end of the Q&A portion of the program. Finally, should you experience any technical difficulties during today's program and need assistance, please click on the Help widget, which has a question mark icon and covers common technical issues. At this time, it is my pleasure to introduce our two panelists that we have today, Holly McCormack, President and CEO of Cottage Hospital, and Rachelle Schultz, President and CEO of Winona Health. Before we jump into our discussion today, it would be great if both of you could tell us a little bit about yourselves and your organization. Holly, why don't you kick us off?
Sure, happy to. Thank you for having me. My name is Holly McCormack, and I am a registered nurse, and I am also the CEO here at Cottage Hospital in Woodsville, New Hampshire. We are an independent critical access hospital located, like I said, in the northwestern portion of New Hampshire. We have a 25-bed critical access plus a 10-bed Geri Psych distinct part unit, so 35 total acute care beds. We also have a level 4 trauma designation, and we also own a multi-specialty rural health clinic that's located across the street from our hospital campus.
Great. And Rachelle, tell us a little bit about yourself and your organization.
Okay, great. Thank you, Jay. So my name is Rachelle Schultz. I'm the CEO at Winona Health. We're located in Southeast Minnesota. We too are a rural primary care healthcare organization. We are, however, a PPS hospital as opposed to a critical access. 130 years that we've been operating in this community and serving the surrounding area. We have our hospital, clinics, senior services, ambulance service, and so forth. I've been here for 23 years as the CEO, 35 years in the healthcare industry, and came from a large multi-state system that had focused on rural healthcare in my early years. So glad to be here today.
Yeah, we're grateful to have both of you, and thank you for joining us as we talk about Medicare Advantage. I know it's not providers' favorite subject, but the unfortunate reality for leaders like you two is that Medicare Advantage is as popular as ever, and more than half of Medicare beneficiaries now are enrolled in Medicare Advantage plans, meaning that that hospitals and health systems are feeling the financial pressure and administrative burden from the private program like never before. So with that said, let's jump into our discussion. I want to first ask you what the challenges that you're seeing from Medicare Advantage right now that are plaguing providers, and how are those challenges trending? Rachelle, why don't we start with you?
Okay, great. Yeah, I don't think this is going to come as any big surprise to the audience. Medicare Advantage is the fastest growing plan, if you will, in our area for sure. Penetration in Minnesota is probably 56, 58%. It's one of the highest penetration levels of Medicare Advantage. And I think particularly in rural communities, we see that even going faster. So if I look at, the last 5 years in my county alone, we've had a 20% increase in enrollment in Medicare Advantage plans. And actually our commercial has seen like a -6%. So we're seeing the government paying plans, if you will, growing fastest with the Medicare Advantage, I think really leading the way. And there's a whole host of challenges, of course, that, come with that. We would think, or we might assume, that Medicare Advantage pays like Medicare does, but in fact, it actually pays less than Medicare, than traditional Medicare. That varies a little bit if you're a critical access or a PPS or things like that. But on average, it's about 91% of Medicare. So where we already are experiencing, reimbursement that is less than the cost of delivering care, this is even, less than that, from the Medicare Advantage, side of things. Then you layer on top of that, issues of the prior authorizations that you have to get for nearly every type of service. In our continuum, while we have the hospital and clinics and in our senior services, that can be a daily thing. It could be an everyday prior auth that you have to renew and renew and renew. So a huge administrative, burden for that. And in the process of doing that, you're also, of course, experiencing denials. And so, we've, just had to spend an enormous amount of time and resource challenging denials, getting those overturned. And, it's kind of crazy because the vast majority, I think nearly every denial that we have appealed has been overturned. But the work of getting that done puts a big burden on the organization when we're all trying to reduce costs and things like that. Now we have more people working prior auth and working denials. And then I think, just adding fuel to the fire is the amount of time that providers are spending writing those prior auths, or facing denials, or having to take phone calls from somebody at a health plan to explain what they're going to do for their patient and all of that. And then that person going, okay, sure, you can do it. And pulling them out of clinic, or pulling them out of surgery, or pulling them out of the hospital, or, things like that. It's just terribly inconvenient. So I think our patients have also been put in really difficult situations, because a lot of them think that Medicare Advantage is just Medicare. And so there's this assumption that I come in, I've got Medicare and it's going to cover things. And then come to find out, like, a service has been denied, or, it hasn't been pre-auth, so they're going to have to wait weeks potentially for something. And I think there's this dissonance out there, for patients about, well, I thought I was under the Medicare program, and what is this? And, and then people who have even had Medicare Advantage and gotten services, if they try to flip back, to sort of regular Medicare, find huge barriers to doing that. So it's almost like you have pre-existing. It's not supposed to be set up that way, but it feels that way to a lot of them. Like, I can't get back into, traditional Medicare. And I think we're just seeing, like, it's an exponential growth in all of these issues. Nothing is really getting better. None of these issues are dissipating. I think the rub that everybody has, whether it's the provider or the patient, I think is just becoming far more difficult, really to navigate. So there's a lot of frustration, and anger and disappointment and all those kinds of, sort of negative emotions, kind of across the board in trying to deal with, what is happening with the Medicare Advantage plans, really like across the board of any of those kinds of plans. So I don't think we're seeing any, sort of relief, in sight. I think we just have to get, better at communicating, a lot of this really to the, end user, which is the patient. But it's really tough in the face of a lot of the marketing that's being done about these plans, and so forth. So it's a bit of an uphill battle, I think, really for all of the key stakeholders that are working in the Medicare Advantage space.
Yeah, great. I think that was a extensive overview, and I think Holly can add on even more to that, I'm sure. But from your perspective, Holly, whether generally speaking or at your hospital, what are the challenges you're currently seeing?
Everything that Rachelle said and more. I think we're all feeling the same pain from this. I can definitely relate to the increased administrative burden that we see with our docs having to do the doc-to-doc phone calls, like you said, and the prior auths. With traditional Medicare and our Jerry Psych unit, we don't have to go through this process of every 24 hours getting another authorization. On Friday, they'll give us one that carries us to Monday. But pulling a provider out to do these calls and to make these calls and to be on hold for hours on end trying to get the authorization is really adding to the administrative burden, within the organization. And, the point Rachelle made about the relief in sight, I don't know that the relief is coming. I feel like, just like you said, the plans are growing in popularity, and on the East Coast, it's exponentially. We used to be in our organization probably close to 55% with Medicare, and now we're down to about 38 because the Medicare Advantage plans are taking away from our traditional Medicare. And in a rural critical access hospital, we look at cost-based reimbursement because of our designation, and when you move to a Medicare Advantage plan, that changes that, and so that's why that's important to us as well. So thinking about all of that, and then for our patients that opt into a Medicare Advantage plan, they often do so because the upfront cost is less for them, or they get some kind of benefit, whether it's vision coverage or something of that nature. And it's not until they need this insurance that they realize what they actually signed up for, and they have this out-of-pocket expenses that they weren't expecting, which is really difficult. I mean, there's probably a very small subset of the population that Medicare Advantage is fine for. If you're, older but very healthy, and it's great for a little while, but when you need the insurance, that's when it becomes problematic for them. So we're seeing all the same things that Rachelle mentioned. We have issues with narrow networks, administrative burden, decreased reimbursement, increased out-of-pocket for our patients. And so I think it's very important that we communicate these issues to our elected officials and let them know what Medicare Advantage means to us in rural healthcare and to our hospitals and our clinics and our patients.
Yeah, and I think the thing you said about relief may not be coming anytime soon is unfortunately true, and putting a lot of the onus on providers right now to figure it out for themselves. And I'm sure we'll get into a lot of strategies that during this program that will hopefully help other leaders. First, I want to talk about that financial health side of things. Obviously, the lack of reimbursement is one of the biggest, if not the biggest, issues with Medicare Advantage right now. How can organizations help offset that, and how can you take care of things and ensure the financial health of your organization to weather some of those storms with Medicare Advantage? Holly, why don't you start us off on this one?
Yeah, that's an interesting question, that to put it on the backs of the providers to figure out how to weather this storm, because it's truly, the death by 1,000 cuts when you look at all the things, especially as, critical access hospital and independent, that we're up against. We're already fighting back from the pandemic. We're already fighting against workforce. We're already fighting against the increase in costs to run our hospital. Our expenses are up about 40% since 2020. And our labor, just our internal labor is about 28% higher than it was in 2022. And so all of these things add on, and then you have this Medicare Advantage come along, and you have the administrative burden of this. We actually have had to add a position within our facility to help us get through all this administrative costs. So I wish I had a good answer to that question. That's the question that I think I would like answered too, is how are we supposed to manage our financial health, around our payers? That is a tricky one. I don't have the answer for the question. I think I have more questions about the question. So maybe Rachelle can give us the answer, the silver bullet to this one.
Yeah,
Rachelle, do you have the answers for us?
Yeah. Well, that is what the million or $1 billion question, and probably what everybody hopes to hear. My short answer to this is that you can't improve the financial health of the organization, to offset these kinds of issues. And I say that because, and I'm going to broaden it a little bit. So, there's Medicare Advantage, which, as we've talked about, is growing and, pays less than Medicare and so forth. But Medicare is already paying us less than cost. Medicare Advantage just pays us even less than that of cost. And then you throw in, Medicaid on top of it. And so that whole, bucket of government payers are paying less than cost. And the sort of warped part of our entire healthcare system is the financing not aligning with care delivery. And so, the financing, mechanism that we all know about is, the sort of hidden tax on the commercial side, so on employers. So, the gaps that we've had with the underpayment on the government, payer side of things is made up by, just getting more from your commercial, side of the business. But as I mentioned, in my earlier comments, and if I look at my county, the number of enrollments going into, commercial plans is down by 6%. And I believe that's actually a function of workforce. So you start, taking, each of these threads and extending it out when we've seen, the workforce go down quite a bit. And that's not just healthcare, that's the whole workforce. Certainly in my community, it's sort of across the board in all businesses where the workforce has sort of disappeared. There's less people going in, there are less people paying into, various plans and all of those things. And so there isn't that offset any longer. I guess, as I think about issues like this, I really go to like, how can we redesign the system? Where can I get alignment? Who will sort of play in the sandbox, if you will, to try to figure out how you can, do appropriate care delivery and actually, get paid for what you're doing. Because by the way, we're doing a lot of things that there is no payment for, as well. And, to make this whole thing work so that we can still, stay viable, to take care, of our communities and so forth. So I don't think you can cut your way out of this. I think it's a redesign issue. And I think we need, sort of, more opportunities and players that are willing to, look at, what might some of those things be. In our case, we started working in, the population health, sort of models, if you will, and in about 2016 we started and we continue now. I mean, and I happen to be a proponent for that because I do think that we're actually seeing better health status of, for people, and we're keeping them out of the ERs and out of the hospitals and all those kinds of things. So I think it's better care and care delivery, but I don't think the reimbursement piece is sort of matched up. So I think, our challenge here is how do we get, away from just fighting about who's got the money into where do we get into redesign and where can we get openings to flow more dollars to, provide the care that's needed by, people in our communities that, we take responsibility for. Otherwise, I think, if we just keep knocking heads around a lot of this stuff and kind of the threats going back and forth, I think ultimately the big loser in all of that are patients, to access to care. So I think this is really a fundamental issue in terms of, where is healthcare in the U.S. going, in the go forward.
I think that is 1,000% correct, Rachelle. And with about 20% of rural hospitals on the brink of closure over the next 2 to 3 years, I think it's a conversation we need to have. But unfortunately, I think it's one that is an entire reboot of the system and how it works. And we're hearing the frustration, from on social media and from the population in general with healthcare. And I think sometimes a misplaced ownership for some of it and some of the problems. I know here in our own community, there's often this feeling that hospitals are rich and that we collect a lot of money. And because the hospitals, I think, are intertwined in people's minds with the payers, they feel like hospitals have a lot of money and, that this shouldn't be a problem that we have to discuss, but it's a real problem. And, I speak a lot about rural because that's what I live, but I think it's important to realize that what we provide to our communities and how fragile and fractured the system is right now.
Yeah, and I think this is an issue that it doesn't matter whether you're big, small, urban, or rural. This is hitting all of healthcare. I mean, we all, during the years of COVID, were the heroes, right? Not anymore. And, the drumbeat that I hear out there, and whether you talk to patients, you talk to employers, or really whoever you talk to, I mean, the issue is like healthcare costs too much. And it's even, I think where we all understood when you look at sort of data of other countries in the US, that's really been socialized now. And I think a lot of folks are looking at things going, is the value proposition there? Why am I having to pay this much, for 15 minutes of time, or this thing or that thing? And it's why you see a lot of people, I think, on the Medicare piece of it, or Medicare Advantage, it's, they go to those plans because they are inexpensive. They're really inexpensive. And they look at those and go, well, I can get vision and dental and hearing, all of those things that I can't get in traditional Medicare. So that looks really good. But, it's like a bait and switch. And, they don't understand that, like, when I really get sick and I end up in the hospital, or I have to have a surgery, or, something big happens, I could be on the hook, for some really big dollars here and never see that coming. So they get blindsided, because there's sort of a sense of protection if you're under, Medicare, that, sort of that whole cost bogey that's out there, somehow you'll have some protection from it. So I think as an industry, we really need to grapple with this issue of, people saying it costs too much. Insurance it's a risk business. And that's, what has to be managed is the risk. And Medicare, Medicare Advantage plans, no different than like regular insurance. They want all the healthy people. They want all your healthy, elderly folks that, are over 65 and really don't have any chronic conditions. And we've got a whole, demographic moving into that with a lot of chronic conditions. So we've got just that demographic challenge, that's like hitting us full force now. We saw it coming, but it's like in play now.
Yeah, there's a lot both of you touched on. It seems like it's going to take a full effort from both providers, payers, and policymakers to have a sustainable future for this. You both had spoken a little bit about the workforce issues that are being worsened by dealing with some of the administrative burden that's being placed on organizations from Medicare Advantage plans. What are some ways that you can mitigate that? Are there ways you can deal with delays and prior authorization processes that can speed things up, or devote your resources a little bit more smartly so you don't have staff constantly just bogged down by dealing with MA plans? Rachelle, why don't you kick us off on this one?
Yeah, so similar to Holly, we I think we have 3 or 4 FTEs that just simply work prior auths. So we've had to bring on staff just to do that work, and then your denials on the other end, and all of those kinds of things. So this one I think is a battle for us, because I think the whole system, and we've heard this and probably experienced this with some of the Medicare Advantage plans, is the use of AI. So there's some criteria in there, whatever, and AI can just boot things out. Those things work 24/7, 365, and they never get tired, right? So that's a battle for us, and I know systems have looked at how do we put in AI, and and then we're going to get the battle of sort of the bots, and who wins out in the end. And I think our real big challenge here is just the visibility of the criteria, such that like if we know what the criteria is, right, we can build that into workflows. We can easily build things in and make sure that's all covered and gets reported through whatever the insurance plan's criteria happens to be. But there is no visibility to that. There's no transparency for us. There's issues of you could do the gold card system, but as much as that's been talked about, I think there's very little of it, and very little trust by, again, all the kind of key stakeholders on, this. And again, I think that's just fundamentally about getting what is the criteria for decision-making, clinical decision-making, for somebody to get, a service, or not. So I mean, I don't think, we can get enough human beings, to sit there and work these denials and everything else. I mean, I do think that, one of the solutions, and probably the best solution, is some sort of automation. But again, I think if we just have automation working on both sides, of the ledger here, that can, just sort of be a battle that we just don't have any controls over. And I don't know if they just gets into like, circles and circular arguments and some of those kinds of things. So, but I think you can be systematic, with automation if you have, again, that criteria. But I don't think that there's a lot of options, for dealing with this. You got, the human piece of it, which is just going to, be hours and expense, or the automation part of it, because this is a task. That's all this is. This is just a task. And, right now, I think the plans, are winning.
Holly, yeah, what can you add to Rachelle's answer there?
Well, similar to Rachelle, we have created a prior authorization team, which we didn't have before. It used to be done by department. And we've created this team in hopes that there can be some recognition of commonality as you're prior authing, one procedure versus another, versus an inpatient stay versus, a radiology study. And so hoping that will be a little bit of a help. But really, I think, it's not about how we can react, but maybe how can we change what the requirement is. And much like Rachelle said, there needs to be some transparency into the algorithms of what gets chosen for denial, what gets chosen, what is the secret sauce to getting your prior authorization, and who is doing that? Who on the other side is making the decision? Is the decision being made by a decision tree that tells them no? Is there a person that is telling them that this doesn't meet criteria? And so I think having more transparency into how the process works on the other side would be helpful, I think, to have as well.
Great. And of course, we've been talking so far about some of the ways providers can indirectly attack these challenges with Medicare Advantage. But the next question I want to ask, and I'm sure everybody in the audience is tuned in to specifically hear about this, but attacking payer negotiations, contract negotiations with these MA plans, how can you go about that? How can you somehow work a rate increase and kind of level out the playing field while still making these relationships mutually beneficial? Holly, I'll kick it to you for this one to start.
So being an independent hospital is very difficult, I think, for us to get out in front of this on our own, to be able to negotiate contracts with Medicare Advantage that can be mutually positive for us. So that is something that's very difficult. But what we can do and what we do is make sure our voice is heard at the American Hospital Association, who is talking a lot about Medicare Advantage when they are speaking with the legislative body and just saying, what does this mean for the country as a whole? But as an individual trying to negotiate that contract, we really don't have a lot of leverage to be able to say, I need this, if not that. And I know that some other bigger systems are able to do that and say, listen, we're not going to accept this plan. We're going to be out of network, if we can't come to this agreement. But it really is not a luxury that I have in my position, unfortunately.
Yeah, it's a difficult balance to find, of course. Rachelle, from your perspective, is there anything that you can do on your end going into these contract negotiations?
Mm-hmm. For me, it's kind of been dependent on the plan. And so I was, able with kind of our main plan that's in my area to actually get them to play a little bit, because we were willing to do some kind of innovative things and some realignment on multiple different kinds of plans. So they were willing to, sort of explore and put something in place, on the Medicare Advantage side. And I think that's what I just reached out, to the plan. Actually, it was the CEO of the plan, and just said, hey, if you're looking for, a site to, like a beta site to try some different things with some, new payment models and care delivery and things, we're willing to play and would really like the opportunity to talk about this more. And so that's kind of how, that opened up. And I would say what I've learned in that too is that I think, as providers, we can be very provider centric and what our experience is. And as plans, I found them to be very obviously plan specific about how plans operate. And just, I think, to get the insights about, decision making that they had, which I think their assumptions were often wrong. And to get more conversation happening with them. Now, I don't have a lot of lives, and I mean, there's multiple, Med Advantage plans, and in any one of them, there isn't a ton of lives in those. So it's unlikely, and I haven't been able to do much with some of the other Medicare Advantage plans other than, get a quality incentive. So, we'll approach all of them and say, hey, do you have anything going on? Do you have something with population health? Do you have something with, quality programs? Do you have some other innovation that you're willing to do? And mostly, I would say it's just been on the quality side, like there's an incentive we can get. So we take it, we put things in place because we're doing that, really across the board. But our numbers are too small. And part of me, I understand that, because I think when these plans are, looking at aggregating lives and managing risk and all of those things, they're looking for like thousands of lives, not, few hundreds here and there, types of things. So I get that. Those are a couple of things. And then one of the things that, a group of us in Minnesota have done, and I think there's a few other states, that are working this way too, is we put a clinically integrated network together of the independent rural hospitals in Minnesota. So as a group, we came together, created this network such that, we can now go to the plans and say, we've got, so many tens of thousands of lives of coverage, whether that's the commercial side or in particular here, the Med Advantage plans, where that becomes a different conversation and it opens the door. And, this is really new for us, because we've just, got about a year under our belt of doing this in the conversations with the plans. But I think that's how they think, and that's sort of the numbers they need. No different when CMS did ACOs and you had to band together to get enough lives and all of that kind of stuff. It's the same, it's the same kind of principles. And I think, it'll work because we've been able to figure out some of those things, on the ACO side. So I think we can do it with the Medicare Advantage, but we need that scope and scale, to be able to say, we can do something, collectively. And so I think there's models out there, for us to do that.
And one of the things, Holly, that you spoke about as an extreme response, a lot of these hospitals, health systems have been terminating their contracts with Medicare Advantage plans and going out of network. Excuse me, and that's placing that is kind of giving them some additional leverage that maybe they didn't have, but it's also coming at the risk of losing patients, right? So my next question is, how do you weigh that that potential strategy of dropping Medicare Advantage plans versus continuing to make sure that you provide care for your community and these patients that, as we said at the start of this program, over 50% of Medicare beneficiaries are now in Medicare Advantage plans. So that's a large chunk of your patient base. So how do you weigh those two sides when trying to determine that? Rachelle, why don't you kick us off on this one?
Yeah, I think this is a really interesting question, because what we also know is that CMS is driving Medicare Advantage, right? So their expectation is like a very much bigger percentage even that exists today is going to be in Medicare Advantage plans. So while I, as a rural hospital, as I look at that, again, I don't have big numbers in any one of those plans. And so there's a couple we can kind of go, yeah, we're not going to do those. And, people can maybe switch over to another one. But I don't think that, getting out of Medicare Advantage, if anything, it's a short-term strategy. I don't think it's the long-term direction that things will go. And I know that there's been a couple of systems in Minnesota that have chosen, what they've done is said, well, we're going to choose, X Medicare Advantage plan. We'll partner with them, but we won't take these other Advantage plans. And to some degree, what that does is then it signals, people in that region or, getting care there, like go into this plan, not those. So I think there's some choices going on, relative to which one, which of the plans are willing to, negotiate and or do something, specific with you, and then start thinning out, the crowd, because there's a lot of, different Advantage plans, that are out there. So I will say that, one of the things that we are doing is for now is we, communicate with people in our community is to sign up for traditional Medicare and really, try to help them understand the difference between the two of them. At some point, maybe they'll be switching over to, Medicare Advantage. But I think them really understanding so they don't get blindsided. I think we have just heard, so much feedback, from patients who felt like they got blindsided, by what was covered, what was not covered. And I think, as Medicare Advantage plans, kind of get themselves sorted out and we get more transparency on what's happening, with all of those, I think some things will smooth out. I will also share, and maybe everybody, kind of knows this, but I really find it very interesting that CMS actually pays more to the Medicare Advantage plans than they pay traditional Medicare. So these plans are, we're given extra money, if you will, to be incentivized to get more people to sign up on those plans. And what it's done is it's made them, a lot of money. It's made these plans a lot of money. And meanwhile, traditional Medicare kind of gets, starved over here. So, I think in the play of like all of these different, points of information and sort of play is like Medicare Advantage plans, trying to figure out where do they fit in the overall landscape and how are they going to continue to morph and so forth. And, if you track on, a lot of stuff, that's, sort of out there in our industry and so forth, you're also hearing a lot of Medicare Advantage plans saying, we may have to get out of the Medicare Advantage, area because we're going to lose money on people. And again, it's that demographic, that's coming in with, more chronic conditions and things like this. So again, I think there's so much dissonance that's happening. But I think our, Medicare Advantage, I think is here to stay. So I think for us, we just have to sort of bide our time and continue to find like openings, to get in there and provide care to, the people who are under those plans in our community.
Holly, do you think this is a viable strategy for a lot of provider organizations going forward?
It may be a strategy for some, but not all. I would say in our community, much like Rachelle mentioned, our numbers are so small that I can say, we'll be out of network with X provider. And I don't think it would have the impact that we would hope. And I would think what would happen is it would actually hurt the patients in our community because they are already in a narrow network and now they'd have to find another place to get their care. So I don't think that is the appropriate solution. I do agree with Rachelle because we know it's going to keep growing. We do have to bide our time and see a little bit how this shakes out, but also making sure that we are doing the education and making sure that people understand what it is that they signed up for. Because I do think a lot of our patients that have elected to have Medicare Advantage, they don't understand their plan. And so finding ways, I don't always agree whether it's the hospital's place to do it, but I think we need to help and make sure it's getting done at maybe the local senior center where education is happening and people know what their options are so that they know what it means if they elect to have Medicare Advantage versus traditional Medicare. So that they know, yes, with Medicare Advantage, your dollar up front is a lot lower, but here's what you're going to be responsible for as you're out of pocket. And so at this point, we have not, as an organization, considered dropping any of the Medicare Advantage plans. We're just trying to find our way forward with them and figure out what that's actually going to look like for us.
Great. And yeah, I've asked both of you some tough questions so far in the program. I want to kind of leave this towards the end to give you guys a bit of a venting session. When I ask you, what reforms would you like to see made to Medicare Advantage? What can policymakers do to help providers in this long-lasting battle right now? Holly, I'll ask you first.
I think first, when I think about the critical access hospitals, the cost-based reimbursement is a big piece of the puzzle, and that's something that it was was originally put into place to help the rural critical access hospitals, and now it's something that's actually being taken away with this, with the Medicare Advantage plans. And so I think that's number one on my list. And I think trying to find a way to work through the prior authorization process, making sure we're not having delays in care because the extended amount of time it takes to get a prior authorization, and then realizing the denials piece of it, what that means, you know, as far as for us getting paid and having our cash flow be interrupted by having to work through these claims repeatedly in order to get them paid. And like Rachelle noted in the beginning, they do mostly end up getting paid. It just becomes the administrative burden. You have to put in the time and the effort in order to get a payment that is due to you. So I think making sure that our policymakers are aware of these things that are wrapped up into this, and they don't know unless you tell them. And so it's making sure that you're involved with reaching out, however that is, with your representatives, whether it's by an email or whether it's a phone call or whether it's hosting a legislative breakfast within your organization, because these folks don't know unless we tell them. And so it's important for us to share what our side looks like too, instead of just seeing the side where, oh, it costs, you know, their constituents less money per, you know, month or per week, however they're paying for this, versus what the overall cost could be to these patients. And so making sure that we are educating folks as much as we can and sharing with the policymakers what that can mean to our organization with this, you know, it's increased burden and, you know, the denials and everything that goes in line with that.
And Rachelle, what would you like to see some of the reforms made?
Yeah, I think those are all great, and I certainly, you know, would support all of that. I think I'd like to see, you know, greater transparency. I think that with the transparency comes accountability, right? So I think, you know, making, you know, all of this on the Medicare Advantage, you know, on the payer sides, you know, far more transparent. And I think even alignment, they need, I think those plans, if we're going to be accountable to things like quality and outcomes and, you know, certain other process sorts of indicators, so should they. So should they. And they're and the measure of just, you know, did that plan make money shouldn't be one of the, you know, primary ones. I mean, I think there's things around access and quality and outcomes, you know, for patients and so forth, you know, and denials and prior auths and turnovers and all of those kinds of things are good, you know, metrics. And there should be just a lot more transparency on that so that we're all kind of all mutually being held accountable. I think that would be, you know, kind of a big value part for patients as well as, you know, everybody else who's sort of involved in all of that. I'd also like to see, you know, like I mentioned, you know, there's a lot more money going into the Medicare Advantage plans, you know, by CMS than it's going into traditional Medicare. And I'd like to see, you know, these plans have to do investments in care delivery redesign. So if their objective is like, let's keep people healthy and, you know, bring costs down and keep people out of the hospital and the ER and this, that, and the next thing, then I'd like to see them use some of those funds to make investments into providers, you know, provider organizations, you know, to again, get to the alignment in care delivery and, you know, the financing part of it. And that could be done, you know, through pilots. You know, I mean, I think we're always looking for ways to innovate and change. So we, you know, if we're stuck in sort of the old structures, you know, and systems of like old models, but we're trying to do something new, you know, and maybe what the Advantage plans are potentially attempting to do, then it's a lose-lose. You know, we've got to get to a point where it's a win-win-win, where patients win, you know, providers win, and payers win. I mean, we have to get this alignment, you know, piece right. So I think, you know, taking some dollars, and that's what I, you know, had asked of, you know, one of the payers here is, you know, make some investment, you know, here to set up new structures and new ways to, you know, provide this care delivery and, you know, help people and so forth. So you get what you need, we get what we need, and we're taking care of patients. Our patients, your beneficiaries, right? And we just need a lot more of that. I think if we're in this big disruptive time, you know, right now, and this is, I would say Medicare Advantage is a big disruptor, then we need to, like, you know, open it up broader, find ways to get more innovation in there, but we need the investment of the dollars, you know, to follow that. So I think those would be, you know, sort of, and that might be a little bit more long-term, but we got to practice doing this because none of us can just change our organizations overnight. You know, we've got to start, you know, moving in a direction. And if we can get some dollars to do that. And if we're all on the same page, we can start moving the dial on this.
And I love that idea that you just mentioned, Rachelle, about collecting the quality metrics from the payers. We all are responsible to collecting and reporting quality metrics. And I think that's a great idea. And one of the things that we have done in New Hampshire in conjunction with our hospital association is actually start a payer scorecard so that we provide data so that we can actually have benchmarks against and see what's happening with various payers and see if there's any trends and actually have that actionable information at our fingertips should we need it. But I love the idea of the responsibility beyond the payers too, to say, here are what our metrics are. And also with transparency to say, here's why this is denied. And here's what we need in order for this to go through the process smoothly next time. So that, not like every single phone call is a different set of requirements. And what I hear from my staff here is they just never know what the question's going to be. It's not like every time we forget to tell them this piece. There's different pieces of information that are asked on different phone calls.
Mm-hmm.
Yeah. Great. Well, that kind of wraps up our discussion in terms of all the questions we had. Thank you both again for your wonderful insight. We are now going to ask our audience members to send in some questions to ask our panelists, bringing us to the Q&A portion of the program. Please submit your questions using the widget as we had mentioned. As a reminder, if you're participating in the program, the widget is at the bottom of your screen. It may be open already and appear on the left side of your screen. Please note that your questions will remain anonymous and will not be viewed by any other audience members. So one of the first questions we've had come in is, do you employ other strategies besides the appeal process to help get resolution with payment delays and incorrect denials? Holly, could you kick us off on that one?
Moving through the denial process is just a very, I don't have any other strategies besides going through the typical appeal process of submitting what's requested or whatever piece of information, or is it on the wrong form, and then putting it back through. And like Rachelle alluded to earlier, and typically after that point, it's covered. I know there's discussion within certain EHRs where insurers can have access to your EHR so that they can access the information on their own to try to avoid that piece, but we have not employed that technology yet. We are looking into it, but we just want to make sure, when you give access to information, that you're giving access to the right piece of information and not any more than we need to be giving access to.
And Rachelle, anything you can add onto that?
Yeah, I think, pretty much it is the denial process. I think one of the things that we're just going live with right now is using AI to help with denials. And, and like, did you miss a code? I mean, if there was an error, what was the reason for the denial, right? And trying to figure those things out. And, and again, I think we're working backwards. We're working blind, where if we were given all the criteria up front, we could just get it right, and have a single piece flow all the way through. But we're having to basically, track and trend, what were the reasons for the denials and can we make the process better? But I think it feels a bit random right now, kind of to the point of having people call in and try to get explanations and all of this kind of stuff from the different payers. And you're never really sure what you're going to get. So it's not a very smooth process right now. And I think it's just hammering on the denials the appeals, I'm sorry, for, the denials right now.
We had another audience member ask, do you all have standing meetings with your Medicare Advantage payers? And if so, how are these structured and how do you find them beneficial? Rachelle, could you provide some insight on that?
The one payer I've mentioned, as a primary for us, we do have regular meetings. We have several regular meetings. One is just on data, and making sure the data is clean and so forth. And others, we have for kind of planning purposes and like other things we could work on and some of those things. I think what's the value of doing that, I can't say that it solves problems all the time, but what it does do is we have a forum And we have the opportunity with people there that, we'll go back and, investigate questions. We've had to become really good about understanding what it is they're looking for. So I think it's helped us get more inside of the, payer head and some of their processes, so that we can kind of go back and figure out what we need to do. But like, I still believe that, the payers are, I think sometimes it's just like, we're just claims processors. Things are just going through, things are falling apart. They're not really, looking at how to maybe always improve some of those processes. And quite frankly, I think the data isn't always that good. And so I think we've just gained a lot more insight on what we have to work with or not, with all of that. But I think we can't put ourselves at arm's length, in terms of understanding what where the payers are at and how to work with them. I think we just have to get far more engaged, whether we like it or not. So this is a way that we've tried to do that.
Rachelle, I'm curious, in the meetings you have with your payers, do you meet with the same team every time? So is there this ability to build this relationship and this reciprocity of information that goes back and forth?
It is the same team, but here's what I would also say is that within their organization, they're very siloed. So you can talk with this team, and they're like, well, we got to go, check with 3 other teams, right? And so they're not putting that whole, picture together. So it's time consuming, and so forth. But at least, again, like I said, it's a place to start and understand how they think and how they work and how they're structured and what they're doing, so that, if there's ways we can nudge them, and or if we can change in a way that helps us, and then we try to do that. But the core team has been the same, which has been really good.
I think it's a great strategy to humanize the situation instead of it being this, Medicare Advantage hospital block, and you don't realize the faces of the people that are in between, because let's face it, networking and relationships can get you a lot of ground, and so it makes sense. And I think it's a great idea.
Yeah.
Another question we have, do you see issues with medical record requests from MA payers? Holly?
I don't see that we see, I'm not sure really how to answer that. I mean, if it's within the frame of a denial, in an appeals process with needing additional information, then yes, we have to provide additional information. But I do think that kind of links to the piece of the puzzle where payers are looking for access to EHRs to gain the information that they need. It's just the worry of, do they gain more information than they need?
Sure. And Rachelle,
and protecting their patients and their PHI.
Of course.
Yeah, I think just with the growth of, denials and things like that, there's just a lot more medical records going. And we too we don't have the electronic connection. So it is a lot of extra work for copying and sending things and doing drop boxes or however, all of these are going. So, but if you're doing a denial, if you're responding to a denial, you always have to have your documentation. So it's always more work out of the medical record.
And we spoke a little bit about this in the discussion, but what are you both hearing from Medicare Advantage patients and their experiences with their plans, and how does that shape your approach? I know you spoke a lot about trying to get them on traditional Medicare as an alternative, but what have you heard from them, and how has that affected your action? Rachelle, why don't you kick us off?
Yeah, so I, in this last year, I've gone out to a number of different locations just to, have conversations with community members and so forth. And in particular, I did target, some of our seniors and where they, kind of hang out and all of that to do, more kind of like healthcare things. But when I get to, Medicare and, Medicare Advantage, that's when these folks get, a little hot and bothered, because they're all of a sudden their stories come out, in terms of denials that they've had, waiting, for services, trying to get onto regular Medicare, so they would have coverage and being denied that. And then the other ones that are sitting in the room going, I had no idea. And, I got to sign up for Medicare, next year or whatever it is. And so wanting that information. And that's really kind of what, caused us to think like we have to do a better job of, educating people on the differences between Medicare and Medicare Advantage. And I will tell you just for myself, my husband turned 65 this year, and all of a sudden our mailbox is full from every Advantage plan, no traditional Medicare, but every Advantage plan that's offered in our region. I would say on a biweekly basis, we get mail. So we'll help you. Here's the thing. Come to these meetings. We'll help you sign up. We've got experts on the phone and all of these, types of things. And so I'm, sort of really understanding firsthand that like this barrage of material that shows up, and then like, how do you choose? And what is helping any of these, folks choose what's best for them? I think when you get down to that level and you're really understanding what people are going, it is terribly confusing. I mean, it's hard enough for people on commercial insurance. Most people don't even know what their coverage is. And you get to, Medicare, people just think it's so much simpler. And in some ways that may be true, but I think the Medicare Advantage has some real potholes in there that, people can get blindsided by. So I'm really trying to have a very broad awareness of like, what is the experience that these folks are having, and, what is our role in helping to mitigate, some of those things, because there's only so many hours in the day and resources that we have. But I think we just want people to be informed so that we're not on the receiving end of like, their anger when something isn't covered.
And Holly, from your vantage point, what have you seen with patients' experiences?
We do hear from patients when they're very surprised at what was not covered for their stay, or what is not being authorized, or that they have to have a prior authorization for something. And I think the point around education is paramount. They do have to know, they do have to understand. The tricky part is being a provider. I don't think it's up to us to steer them, or it's not appropriate for us to steer them into one plan or the other. But I do think we need to make sure they have all the information to make that decision on their own, and to understand what they're electing and what each decision means. And so that education part is key. And I think that when they hear Medicare and Advantage, well, Medicare is good, but Advantage must be better and it costs less. And so, and like Rachelle said, it's advertised everywhere. It's on the TV. If you're ever, at home at 11 o'clock in the morning, it's on your TV. If you're awake in the middle of the night, it's on your TV. There's the commercials, and, here's what you get that you don't get with traditional Medicare. And so that's what they hear. It's not, it doesn't tell them what they don't get or what their responsibility will be financially, if they don't have coverage. And it's not even to say like, then the piece that isn't covered, how is that going to get paid if they don't have the resources to pay that? What happens to that? And that ends up being something that the hospitals just don't recover. And so thinking about that piece of it as well. So, education, partnering with the senior centers to make sure that they understand and that they have the education, or the people to provide education, I think is super important.
Of course. Well, that is all the time that we have today for questions. I apologize if you had submitted a question and we didn't get to it, but great discussion, great insight as always. In closing, please note that our next program on April 1st will cover the winning edge for cost containment. A live clickable link will appear at the close of this program, taking you right to the registration page for that event. Remember to follow along all week as we continue to cover strategies for battling Medicare Advantage on our website at healthleadersmedia.com. I want to thank our panelists once again for an excellent discussion. And finally, thank you to you and our audience for attending and participating. We hope you enjoyed today's program, and we look forward to seeing you during our next program on cost containment.